Gil, thank you very much. And I'm looking out at the audience. I think that most of you must be from the West Coast, because if you were from the East Coast or the upper Midwest, you would not be in this room if you've walked outside lately. Anyway, I do appreciate your being here. If I can make this. So I went to the Inova health system in the fall of 2010. And I went there to build an institute to improve the health of really a diverse community of patients that is served in the Washington metropolitan area and Northern Virginia. And to work on the problem of the application of genomics to medicine, and ideally medicine in real time, which is hopefully the future. We knew that to work on some of the issues, we needed, especially the analytical issues and about making this information valuable at the point of care, we needed to first generate a rather large scale of information to work with. So the goals of our efforts are really focused on redefining disease through genomics and to work on the chronic diseases, which really account for probably 90 to 95% of the patient populations that we care for in our healthcare system. To do that, our goals to study are the biomarkers of disease. The earlier we can diagnose, the better, especially in cancer, for example. We wanted to know as much as we could about the disease in terms of its genomics. What are the causes? What are the drivers of chronic disease? What are the relationships of variants to the critical cell pathways that really create the phenotypes of the disease? And we wanted to be able to work with complex information, not just genomic information, but health information, personal information, to integrate those data sets to be predictive about disease. So the real challenge, I believe, in this is not generating genomic information. You heard talks this morning about how much progress we've made, how much information we can generate, not just the whole genome sequence, but also the mechanisms that control the expressions of genes that are so critical to diseases that we treat each day. So we need to be able to integrate not only this genomic information, but we need able to integrate that with one's personal information, personal health, environment in which we live, the stresses that are part of our daily lives. All of these affect the chronic diseases that we have or will have throughout our lives. If you look at any of the chronic diseases, if you think about them for a moment, whether it's cancer or arthritis or diabetes, if you're in medicine, you realize right away that there are many expressions of that disease. Not every patient is alike. In fact, almost every patient, as we were talking about earlier with cancer, is really an N of 1. When we began to establish the Institute at Inova, I wanted to focus on family sequencing, realizing that could increase the power of the information that we were getting, the accuracy of that. We talked about working with newborns. We weren't sure that we could actually do that. We spent a lot of time talking about the opportunity to do that in a not-for-profit healthcare system. So we worked a lot with the physicians, and we were able to set up what I think is actually a model of chronic disease. Yes, it addresses a very important healthcare issue, that of preterm birth. That accounts for about 10 to 12% of live births in our country. It accounts for about $28 billion a year in healthcare costs. It is a significant stress or strain on any family who has had a premature baby and had that baby spend time in the neonatal intensive care unit. All those things are true, but it's also a very complex entity. It involves many different tissues, certainly the mother who's hosting this developing fetus. It includes the placenta, which is actually not just an oxygen exchanger, but an organ in its own right, an endocrine organ in its own right. So this is a very complex entity. We jokingly said that one of the good things about it was that it had a 9-month duration, and that made it a little more navigable for research purposes. But it's a very heterogeneous disease. We launched, as you can see on this slide, in really the second quarter of 2011, our first study called the Preterm Birth Delivery Study. And in that study, we consented families as they entered the delivery process, if you will, and had great success on getting young people, young families to consent to being part of the study. We collected specimens at the time of birth from the mother, from the father, using whole blood and white cell DNA for genomic sequencing. We collected buccal smears, saliva from the baby, as well as some portion of the heel stick sample that was obtained on each newborn, and cord blood and cord specimens, and also wherever possible, we have obtained placenta and have an actual organized program about where the biopsies or samples are taken from the placenta, and all that is in a rather large biobank. We really had initially targeted about 500 families. We've been able to extend that now to 1,088 families as of the end of December, of which 345 of those families are preterm deliveries. So we've essentially now closed this study with over 1,000 families in it. But we do continue to add those that are very early or extreme preterm in terms of their delivery. I put this PowerPoint in to just give you a sense of what the Institute is doing in terms of its maternal child or maternal newborn studies. So you can see on the top line the preterm birth study that I just showed you. What I think is our most important effort is what I call the longitudinal cohort. This study we launched in July of 2012. We have, as you can see there, already over 1,000 families that have been consented and are part of this longitudinal study. We are in over 5 OB practices with our CRAs, our nurses. They consent these families right around the end of the first trimester. We follow them through pregnancy, collect a lot of personal information, health information, yes, but also personal information about the environment they live in, the stresses that they have in their lives, and so forth, the study-specific kind of information, as well, of course, their health record information. We also have a very large neonatal intensive care unit in our main 1,000-bed hospital, about 100 isolates. So as you can imagine, we see a lot of babies with a variety of very complicated congenital abnormalities. And so a year ago, we put in place a clinical research trial that allows us to consent families in the neonatal intensive care unit, and we focus on families where there is not a clear diagnosis. Standard testing has been done, they haven't obtained a clear diagnosis. Much to my surprise, there are over almost 200 families that leave our hospital without a clear genetic diagnosis for their complicated diseases. We've consented, as you can see already, a significant number, 63 of those families. About half the families are very interested in following up. Here's the example of the longitudinal study. I mentioned again that we're consenting at the end of the first trimester. We've had good acceptance to this trial. We follow the family and the newborn then every 6 months. We interact with the family, we get information about behavioral development, about all the development of cognitive skills, motor skills, and so forth. All that information is collected. Obviously, if any diseases occur, we have that information, and we're out now already collecting 18-month follow-up data. It's, as I said earlier, I think relatively straightforward, and as you saw in the slides earlier, that cost of obtaining the genomic information isn't the problem. The challenge for us, and the challenge for us in our studies, has been managing a large amount of information depicted on this slide. And we've been doing that in a cloud situation with the help of Amazon. We bring the clinical information and the genomic information together in that environment. One of the things that we initiated back in the summer of 2011 is that all of our bioinformaticists, the people that are working on the analysis side of this issue, have to bring their tools into this environment. We do not let information out, so everyone comes into the environment and works there in the environment, and we can keep a visual, if you will, record of what is taking place in terms of analysis. This is not inexpensive, and it, I believe, is going to be one of the real challenges for all of us in the future of using genomics in healthcare. How do we manage this scale of information, the integration of this, and so forth. In our newborn study, we've done a lot of analysis. We're getting papers ready to come out. They'll be out pretty soon. We've found relationships between clinical phenotypes and signaling pathways, not unexpected, but again, stressing the complexity of this. We've also found, much to our amazement, that the people that are in our study come from over 80 different countries. It's not where they say their parents came from, it's where they were actually themselves born. And with that kind of information, we've been able to begin constructing what we call ancestral specific reference genomes. And those of you working in the genomics area know how important that is in the medical application of whole genome sequencing, filtering out all the variants that we have. We've had one, this is one example of some of our efforts with the private sector. Here's a drug company that had a drug that failed in clinical trial, but in all of the preclinical testing appeared to be something that should work. And so they gave us the gene involved, the variants involved, that we were able to go into our database and very quickly, within actually a day, tell them that probably the reason was that only 51 of the European ancestry had the right variants that would allow this drug to be helpful. Back to our patients in the neonatal intensive care unit, you can see this particular male that was born at 34 weeks, spent 45 days in the ICU, and you can see had this variant in CDKN1C associated with the image syndrome. And you can see the family history that we had on this particular variant through the family affecting this male. So we were able to take that information, be sure the pediatricians knew that the hypoaldosteronism was important, and they should be careful about that in managing the health of this baby, and also to inform the families. Okay. And I'd like to thank these people who have been involved with this project. Thank you very much.